I'm very excited to welcome all of you here for the 72nd annual Alfred A. Strauss visiting lecture. And this is a highlight of the year in the Department of Surgery, a very important event, something we've been able to continue in spite of a pandemic. Although we'd rather be in person, this is the next best thing that we're able to welcome Dr. Ford and to welcome all of you. For those of you that don't know me, I'm Doug Wood. I'm the chair of the Department of Surgery. But I'm going to turn things over to Dr. Paul Ramsey, who's the Dean of the School of Medicine at the University of Washington and also the Chief Executive Officer of UW Medicine, so that he can welcome you and introduce the Strauss Lecture.
Thank you very much, Dr. Wood. Good afternoon to everyone, although I guess I should say good evening to Dr. Ford. Thank you so much for joining us. It is my privilege and honor to welcome you all to the 72nd Annual Strauss Lecture. In presenting the 72nd Annual Strauss Lecture, the Strauss-Friedlander family is carrying on a tradition established many years ago by Dr. and Mrs. Alfred A. Strauss. Born in Germany in 1881, Dr. Strauss came to Colville, Washington at the age of 10. He was an honors graduate of the University of Washington in 1904 and an outstanding member of the Alumni Association. Dr. Strauss received the singular honor of alumnus summa laude dignatus in 1951. Dr. Strauss was a football and baseball star as an undergraduate. As an alumnus, he was active in the recruitment and establishment of scholarships for athletes at the University of Washington. He personally recruited more than 75 football players from the Chicago area, 5 of whom became college All-Americans. In 1981, he was elected to the Husky Hall of Fame. I think the current Husky football team could use his recruiting ability and mentorship. Dr. Strauss received his medical degree at Rush University of Chicago Medical School in 1908, graduating first in his class. He interned for 2 years at Michael Reese Hospital in Chicago and completed a brief surgical fellowship under Professor Enderlin in Heidelberg, Germany. Dr. Strauss then returned to Chicago, where he spent his entire medical career. He possessed a rare combination of skill, vision, and drive, and was intimately involved with and leading many, quote, firsts, end quote, in the advance of medicine. These advancements included refinements of pyloroplasty, subtotal gastrectomy for peptic ulcer disease, surgical advances in inflammatory bowel disease, and the first description of an abdominal wall zipper to facilitate frequent re-explorations. Dr. Strauss and his 2 brothers, Herman and Siegfried, also University of Washington undergraduate alumni, founded Weiss Memorial Hospital in 1953 in Chicago. Dr. Strauss is also well remembered for his influence in founding the School of Medicine at the University of Washington. On July 22, in 1944, Dr. Alfred Strauss, as a member of the proposed medical school committee, met with Governor Langley and strongly advocated for state funding for a new medical school. Our school was founded then in 1946 with Dr. Strauss's efforts being a key to the establishment of our school. The appropriation bill was signed by the governor on March 15, 1945. So we owe our school really to Dr. Strauss. True to his continued interest in our institution, Dr. Strauss sponsored a surgical lectureship in 1950 for the Department of Surgery, and these lectures have been a prestigious annual event ever since. Today's program is supported by the Alfred A. Strauss, MD, Endowed Lectureship in Surgery, established by the estate of Miss Marjorie Friedlander, daughter of Dr. Strauss. And our annual lecture is very generously supported by contributions from Dr. Strauss's nephew, Dr. John Strauss, and his grandson, Mr. John Friedlander. We are fortunate to have Dr. Strauss and John Friedlander with us in this virtual Strauss lecture today. It is my pleasure to honor Dr. Strauss once again at this 72nd annual lecture. Dr. Wood.
I just want to add my appreciation and thanks also to Dr. John Strauss and Mr. John Friedlander, who've both become good friends throughout my time as chair, as I've seen their commitment and support to the Department of Surgery and to this annual lecture in the name of their uncle and grandfather. So thank you, both John Strauss and John Friedlander. I appreciate you being here. I look forward to seeing you in person when we can be in person again. For those of you that are near the office of the Department of Surgery, stop in and see the portrait that we have of John Strauss in our departmental offices. So it's really my privilege to introduce Dr. Henri Ford, who is our Alfred A. Strauss visiting professor, visiting lecturer this year. Dr. Ford is a friend and colleague as we've gotten to know each other in the Board of Regents in the American College of Surgeons, and I appreciate him being willing to spend today with us. As introduced earlier today, Dr. Ford is Dean and Chief Academic Officer of the University of Miami Miller School of Medicine. Dr. Ford gave a very thoughtful description of his path from roots in Port-au-Prince, Haiti, to being Dean of the School of Medicine at the University of Miami in his lecture this morning. Dr. Ford was an undergrad at Princeton. He then attended medical school at Harvard, did his general surgery training at Cornell, and his pediatric surgery fellowship at Pittsburgh. Dr. Ford then stayed at the Children's Hospital of Pittsburgh from 1993 to 2005 and became program director, then division chief, director of trauma, director of surgical research, co-director of fetal medicine, and ultimately surgeon in chief, really rising through the ranks in terms of academic promotion as well as leadership within CHOP. He then was recruited to USC and the Children's Hospital of Los Angeles, where he also served as surgeon in chief before being recruited to the University of Miami as the Dean and Chief Academic Officer in 2018. As I mentioned, Dr. Ford is a member of the Board of Regents of the American College of Surgeons, has a major leadership role in the American College of Surgeons, and is a place where we've gotten acquainted and where I've appreciated his wisdom and his experience. He's been the president of multiple surgical organizations, the Society of Black Academic Surgeons, the Association for Academic Surgery, the Surgical Infection Society, and the American Pediatric Surgical Association. Along the way, Dr. Ford has received innumerable awards, but I want to concentrate particularly on the humanitarian awards. He's received the Hispanic Health Leadership Award, a humanitarian award from the Black Women's Physician Association, from Haiti and the Caribbean Physician Association, from the Association of Academic Surgeons and Association of Academic Surgeon Foundation, that actually established a research fellowship for underrepresented minorities in his name. He also received the Arnold P. Gold Humanism in Medicine Award from the Association of American Medical Colleges. We learned earlier today that Dr. Ford grew up in Port-au-Prince, Haiti. His father, a preacher who spoke out against inequality in Haitian society. And Dr. Ford is the sixth of 9 children. In his academic work, he's conducted groundbreaking research on the pathogenesis of necrotizing enterocolitis, one of the most common and lethal disease affecting gastrointestinal tract of newborn infants. And his work has led to new insights into the treatment of necrotizing enterocolitis. I'll emphasize just in the end here, the work that he's done in his home country of Haiti. In 2010, he traveled to Haiti after the earthquake there to provide surgical care to children injured in the catastrophe. He initially operated on patients in a closet in the US Embassy, and then ultimately on the USS Carl Vinson. He helped to set up a field hospital in Port-au-Prince and recruited other healthcare workers and ultimately injured children and adults to get care there. He became a bridge between American healthcare teams and Haitian healthcare teams and was named a Haiti Health Hero. He continued to return to Haiti, and I know with the recent earthquake, he and I have talked, and he continues to do work in his home country. One of the amazing things that he has done is in 2015, he performed the first successful separation of conjoined twins in Haiti alongside surgeons that he helped to train. So I want to emphasize that Dr. Ford is a skilled surgeon, a groundbreaking academic surgeon, an inspiring educator, and a visionary leader. He's a deeply caring humanitarian who follows his father's footsteps in advocating for equality and justice, and the footsteps of his mother in serving others. He told us today about 5 principles for being a great physician and surgeon. Those principles were excellence, integrity, moderation, hiring the best people, and not taking yourself too seriously. Dr. Ford, I hope I got those right. Those are truly inspiring words of wisdom that you gave us. And I'm very proud to have you here, welcome you here. And Dr. Ford will be talking to us about the imperative of diversity in academic surgery. Thank you.
Wow. What a wonderful introduction. Thank you so much, Doug, for this generous and over-the-top introduction, and certainly for the singular honor of delivering the 72nd Alfred A. Strauss Lecture. When I look at the list of prior illustrious Strauss lecturers, iconic figures in the annals of American surgery, I'm truly humbled to join such an elite group. Let me add my heartfelt thanks to the Strauss and Friedlander family for immortalizing Dr. Alfred Strauss through this lectureship. As I've shared with you before, I had been looking forward to visiting your department in person to reconnect with so many dear friends, starting, of course, with your chair, Doug Wood, my friend and fellow ACS regent. A couple of people who really inspired me and mentored me and supported me during my career, Drs. Carlos Pellegrini and Ron Mayer. My former chief resident and role model, Dr. Gabriel Aldea, and Gabe, you'll always be a role model to me. My fellow Pittsburgh colleagues, Drs. Pat Healy and Jorge Reyes. My fellow pediatric surgeon colleagues, Dr. John Waldhausen and Bob Sawen. And Bob was a resident at the Brigham when I was a medical student going through. My committee on trauma and surgical infections colleague, Dr. Eileen Balger. My mentees from the Society of Black Academic Surgeons, Drs. Andre Dick and Lara Oyotunji. And of course, several other colleagues with whom I have worked and collaborated over the years, whether the Board of Regents or Board of Governors, people like Lori Langdale and Karen Horvath, just to name a few. And I'm sure there are others that I'm forgetting, so forgive me. So unfortunately, we have to meet virtually, so I send a virtual hug to all of you. There's no question that we have been living through some tumultuous times these past 2 years. As I reflected on some of the challenges facing our society, I decided to focus my talk on the imperative for diversity in academic surgery. Is the outline of the talk. I'll discuss the rationale for a diverse medical workforce to promote health equity, I'll examine some of the barriers that prevent underrepresented minorities and women from advancing to leadership positions in American surgery, and the challenges they face in trying to overcome these barriers and in addressing health disparities. More than 5 decades ago, in a speech to the Medical Committee on Human Rights, Dr. Martin Luther King stated that of all the forms of inequality in contemporary American society, injustice in healthcare is the most shocking and inhumane. At that time, the infant mortality rate for Blacks was twice that of whites. And now, more than 50 years later, although the overall infant mortality rate has improved for all ethnic groups according to the CDC, the infant mortality rate for Blacks, 10.75, is still more than twice that of whites, 4.6. And this disparity may still be growing. Indeed, health disparities between underrepresented minorities and whites remain a vexing problem in contemporary American society. URMs have shorter life expectancy and suffer a disproportionately higher rate of cardiovascular disease, as we learned from Dr. Oyetunji today: cancer, birth defects, asthma, diabetes, stroke, sexually transmitted diseases, mental illness, and COVID-19. They're white counterparts. Now, the etiology of such disparities is multifactorial in nature and includes, but is not limited to, inequalities in income and education, access to and quality of healthcare, racial and ethnic discrimination, cultural issues, as well as intrinsic biological differences among ethnic groups. In fact, in its seminal report on health disparities, the National Academy of Medicine argues that after adjusting for education and economic status, unequal treatment due to racial prejudice underlies health disparities, despite equal access. Thus, equalizing access to healthcare may be insufficient to eliminate health disparities. So therefore, just like Martin Luther King, these distinguished scholars posit that the problem of health disparities is tantamount to one of moral failure. It is well established that underrepresented minority physicians are significantly more likely to practice primary care and to work in impoverished or underserved areas than whites. And if you ask members of the incoming medical school class, what is the likelihood that they will practice in an underserved area? 55% of Black students will respond in the affirmative, compared to 21% of white students, and 34% and 36% for Indigenous and Latinx students. In fact, a recent report by Greenwood and colleagues examining 1.8 million hospital births in the state of Florida between 1992 and 2015 demonstrated a significant improvement in mortality when Black infants were cared for by Black physicians. Thus, given the propensity for underrepresented minorities to practice in impoverished or underserved areas, and given the National Academy of Medicine findings of unequal treatment due to racial prejudice, in order to mitigate the effects of racial and ethnic discrimination, we must develop a culturally competent and diverse workforce to provide optimal healthcare to the entire nation. The same argument applies for the research agenda on health disparities. As stated by Jordy Cohen, past president of the AAMC, what people see as problems depends greatly on their particular ethnic, cultural, and ethnic filters. Thus, solutions to existing health disparities will require a racially, ethnically, and culturally more diverse research workforce. Now, this slide shows the ethnic composition of the US population in 2019. As you can see, self-declared Blacks and Latinx or Hispanics accounted for 31% of the US population. Now, although Blacks and Hispanics account for 13% and 18% of the US population respectively, they only accounted for 5% and 6% of the academic physician workforce respectively. And this slide shows the ethnic rank of US medical school faculty from instructor to associate professor. Again, as you can see on the left, Blacks and Latinx account for a mere 2% and 3%. They account for 4%, 4 to 5% in each category. And when it comes to tenured faculty, Blacks and Latinx account for a mere 2% and 3% respectively, compared to 81% for their white counterparts. This trend is even worse for academic surgery, where Blacks account for 2% of tenured faculty and Latinx for 1.5%. Now, the prospects for URM academic surgeons are not that much brighter because Blacks and Hispanics, Latinx, account for only 16% of the surgical residents. And even if all of them went into academic surgery, we would still face a significant gap. Now, in 2003, Cooper and colleagues published this important paper about an impending crisis in American medicine. And this was subsequently reconfirmed by the WMC in 2019. They argued that this crisis was due to an aging population, a shortage of physicians in various specialties, significant health disparities between underrepresented minorities and whites, and a shortage of URM physicians. Their proposed solution was to train or import more physicians. Now, let us examine what happened since that report was issued back in 2002. Since 2002, the total number of medical school slots increased by 5,513. That's a 31% increase. And during that period, the percentage of African Americans and Latinx in the US population grew by 6.5%. Yet, instead of increasing, the percentage of Black and Latinx medical school graduates decreased from 13% to 11.5% in 2019. We are going in the wrong direction. And in fact, during the past 3 decades, there has been little growth among African American medical school graduates. And when it comes to Black male matriculants, the annual increase has averaged only 3.5 students since 1978. In other words, it's pretty much static. Now, although the data for 2019 and 2020, I would say, suggests that the number of URM matriculants is improving slightly, Blacks and Latinx account for only 13% of matriculating students, even though they account for over 31% of the population. Now, factors accounting for recent trends in medical school applicants include family income, which is a proxy for the quality of education, and reading achievement in the 3rd grade. Right, here's one of my favorite quotes. It takes a bachelor's degree to make a medical student, and it takes reading proficiency at age 8 to make a doctor at age 28. And it takes resources to make all that happen. In essence, if you fail reading comprehension in 3rd grade, the die is cast because there is a 60% chance that you'll spend 1 to 2 nights in jail by the time you turn 30 years old. The slide shows the poverty rate in the US by ethnic group. Now, surprisingly, Blacks and Latinx lead the way. The same is true for single mother families. This is particularly important because previous studies have shown that 40 to 50% of Black students live with a single mom and thus are at greater risk of being below the poverty line and therefore have access to inferior education. According to WMC, by 2032, the US population will increase from 328 to 359 million. Nearly 122,000 additional physicians will be needed for an aging US population. Blacks and Latinx will account for over 37% of the college-age population. Those are the 18-year-olds, the group from which we get our future doctors. Therefore, underrepresented minorities will need to play an important role in the medical workforce in order to meet the health needs of the American people. But where will they come from? This slide shows the percentage of 12th graders who are at or above proficiency for science. As you can see, Black and Latinx students seriously lag behind whites and Asians. And note the gender disparity among the white students. The same is true for proficiency in math. Blacks, Latinx, and indigenous students are far behind white and Asian students. And when one looks at the pipeline for future professionals, we see that Blacks and Latinx have a lower high school graduation rate and a significantly lower matriculation rate for college or graduate school than whites. Thus, the rationale for diversity stems from the projected significant increase in the US population, the need for more physicians to take care of this aging population, the increasing proportion of underrepresented minorities in the US population, the increase in health disparities between URM and their white counterparts, and the fact that underrepresented minorities account for a significant fraction of 18 to 24-year-olds, the category from which we must derive our future doctors. Now let us examine the barriers that prevent underrepresented minorities from advancing to leadership positions in American surgery. One of the challenging problems that impede the development of surgical leaders from underrepresented minority groups is the vicious cycle created by a limited pipeline, lack of role models, lack of mentorship, inadequate counseling, inadequate financial support, and inadequate research infrastructure. Here's a schematic model for leadership advancement in surgery. Now, take a surgical trainee who is like a pluripotent stem cell. Now, expose this pluripotent stem cell to really excellent growth factors like outstanding role models at the University of Washington Department of Surgery, role models who personify excellence, then the resident is likely to evolve or differentiate into an emerging leader. Now, this resident becomes an attending in a top department, such as the University of Washington, where he or she is exposed to enlightened leadership, a few former presidents of the American College of Surgeons. And that resident is nurtured, mentored, and sponsored to join key academic surgical societies, and you now have a bona fide surgical leader. In contrast, if the surgical trainee is from an underrepresented minority group in medicine, he or she faces an already limited or poor pipeline. And if the resident attends an average or mediocre training program where they encounter few role models, few mentors, few sponsors, and have inadequate access to resources, then he or she is unlikely to evolve into an emerging leader. And furthermore, if this resident takes a job in a department with few mentors, few sponsors or role models, and limited access to resources or infrastructure, he or she becomes prematurely, terminally differentiated, and thus never becomes a surgical leader. In fact, a survey of faculty from 26 medical schools and an independent survey of surgical residents reported that compared to non-underrepresented minority faculty or residents, the URM faculty and surgical trainees feel like outsiders because of a lack of inclusion, a lack of trust, as well as racial or ethnic discrimination. Yet, URM faculty and surgical residents were more likely to aspire to positions of leadership than their white counterparts. Unfortunately, isolation and disillusionment lead URM faculty and trainees to abandon academic surgery, thus further eroding the potential pool of future leaders. Finally, let's consider the challenges facing women and underrepresented minority leaders in overcoming barriers and addressing health disparities. For academic year 2018 and 2019, women accounted for a slightly greater proportion of applicants and matriculants to medical school than men, but for fewer graduates. The slide shows the gender composition of US medical school faculty. Women account for 42% of the faculty. As you can see, as was stated earlier, for the UW experience, the Department of Surgery, women account, the vast majority of women faculty are instructors or assistant professors. When we examine the tenured faculty according to gender, we see that women account for only 26% of tenured faculty at US medical schools. Among women faculty, URM account for only 13% compared to 61% for whites and 20% for Asians. This slide shows that women faculty by rank and ethnicity. Blacks and Latinx account for a fraction of women faculty in each category. Women account for only 18% of all department chairs, but only 6.3% of surgery department chairs. Among other clinical department chairs, among women clinical department chairs, Blacks and Latinx account for only 13% compared to 74% for whites. Fortunately, more women are choosing general surgery and surgical subspecialties for residency since 2005. Thus, the pipeline is growing, although, albeit quite slowly. As we heard this morning, it is a leaky pipeline, but yet it appears that we're starting to plug some of those holes, although not fast enough. URM and women faculty who aspire to become leaders in academic surgery face a daunting task. They must establish legitimate academic credentials defined by gender, race, and colorblind metrics, consisting of publications in high-impact journals, selection for institutional leadership positions, national recognition as evidenced by selection for leadership positions in academic surgical societies, NIH study sections, national committees, and perhaps more importantly, promotion along the academic ladder, which is rooted in demonstrating a tradition of excellence. They must serve as mentors by attracting, inspiring, nurturing, sponsoring, and ultimately liberating the surgical trainees and junior faculty so that they can continue to flourish on their own. But yet they must continue to advocate for them from a distance. But we should never equate advocacy with lowering the standards, because there is no satisfactory substitute for excellence. They must become role models with broad appeal to convince deans and CEOs to expand opportunities for URM and women. Active community engagement must be part of the surgical leaders' portfolio. They must champion grassroots advocacy to address pipeline issues, combat prejudice, and help reduce health disparities at a policy level. Trailblazers such as Charles Drew, Samuel Coombs, Salvatore, Claude Organ, Haile DeBoss, and L.D. Brick, to name a few, have been able to overcome all sorts of barriers to reach the pinnacle of American surgery. How did they do it? They had one thing in common. They shared a relentless pursuit of excellence, a relentless pursuit or passion for the pursuit of excellence. As stated by Charles Drew, excellence of performance will transcend artificial barriers created by men. Let's take a closer look at some of these trailblazers. This is Charles Drew. He epitomized excellence. His brilliant work while a research fellow and surgery resident at Columbia University helped to elucidate the causative factors in the pathogenesis of shock with his mentor, John Scudder. His doctoral thesis on bent blood provided the basis for separating the components of whole blood, such as plasma and red blood cells, and for establishing the modern blood bank. Not surprisingly, he was appointed the first director of the American Red Cross Blood Bank. He helped Jack White become the first African-American fellow at Memorial Sloan Kettering Cancer Center. I'll come back to Jack White. Sam Kuntz distinguished himself as a superb academic surgeon. His seminal work on the mechanism of rejection of homotransplanted kidneys was published in Nature in 1963. He became the chair of surgery at State University of New York at Downstate, and the first and only African-American president of the Society of University Surgeons. His untimely death abbreviated his meteoric rise in academic surgery, which almost certainly would have taken him to the pinnacle of American surgery to become the president of the ACS. This distinction, president of the American College of Surgeons, belonged to LaSalle D. LaFolle Jr., the first African-American or URM to hold this esteemed and revered position. His brilliance was evident in high school when he graduated valedictorian of his class at age 15, a feat he repeated at Florida A&M and later at Howard University School of Medicine. This was followed by general surgery residency at Howard under Charles Drew and surgical oncology fellowship at Memorial Sloan Kettering Cancer Center, which was facilitated by none other than Jack White, Drew's mentee or protege. Dr. LaFolle returned to Howard, where he quickly rose through the ranks to become chair of surgery. He was the first African-American president of the American Cancer Society and the Society of Surgical Oncology. He mentored hundreds of African-American surgeons. Rhode Organ holds the distinction of being the first African-American chairman at a predominantly white medical school. He was the first African-American editor of Archives of Surgery, and under his leadership, the journal had the largest circulation of any surgical journal. He was the second African-American president of the ACS and also served as chair of the American Board of Surgery and the Residency Review Committee. Most importantly, he was one of the visionary leaders who founded the Society of Black Academic Surgeons. His legacy is that he mentored all the current African-American surgical leaders, including L.D. Britt. This photo was taken at the inaugural SBAS meeting in 1989, which was hosted by Dr. Dave Sabison at Duke. Among your attendees were all the icons of American surgery at the time, including Art Donovan from USC, Jim Thompson, who's also depicted in this picture, Tom Showers, who was not shown in this picture, and numerous other icons of surgery. Dr. Asa Yancey graduated from Morehouse and then was the first African-American to graduate from the University of Michigan Medical School. He trained under Charles Drew, and he published, and most importantly, which is significant for me as a pediatric surgeon, he published the contemporary approach to the management of congenital megacolon, Hirschsprung disease, in the Journal of the National Medical Association more than 10 years before Franco Suave published his technique in the Journal of Pediatric Surgery, and they're almost identical. Yet, the procedure to correct Hirschsprung disease is known as the Suave procedure rather than the Yancey procedure, except in my operating room where it's called the Yancey procedure. Dr. Yancey was elected to the National Academy of Medicine. Haile Debas helped develop UCSF into a world-class medical school. And you can see all of the things that he did. Chair of Surgery, Dean of the Medical School, Chancellor. He's past president of the American Surgical Association and the Society of Black Academic Surgeons. He has mentored hundreds. LD Britt holds the distinction of being the first African-American to hold an endowed chair in surgery. He has been president of everything surgical, including the American College of Surgeons, the American Surgical, Halstead Society of Southern, you name it, he's been there. He was also elected to the National Academy of Medicine among his many honors. While one can argue that excellence is the essential scaffold for success, it is truly the quest for significance or the desire to make the biggest difference possible in the lives of others and in their community that propelled these trailblazers and role models to the pinnacle of American surgery. Unfortunately, like these trailblazers, women surgeons in contemporary American society face tremendous challenges as they try to ascend into leadership positions in American surgery. A recent report revealed that 40% of women physicians go part-time or leave medicine altogether within 6 years of completing residency for a multiplicity of reasons, including gender discrimination, salary inequity, gender bias, and work-family conflict, to name a few. Work-family conflict can markedly affect productivity and promotion for women faculty. In fact, during the global pandemic, women in surgical specialties reported decreased academic productivity because of work-life family conflict. This must be considered when making promotion and tenure decisions. A greater proportion of men than women are promoted at 7 years. But over 10 years, women are able to significantly narrow the gap. Therefore, we should increase the tenure clock for our women faculty. We must never forget the importance of mentorship and sponsorship when it comes to faculty development and promotion. I'm reminded of Sir Isaac Newton's letter to Robert Hooke in 1676, in which he states that if I've seen further, it is by standing on the shoulders of giants. That's the essence or raison d'etre of the Society of Black Academic Surgeons, a mentoring organization established to foster the development of Black and Brown academic surgeons. It has produced a number of key leaders in American surgery over the years, including 2 former presidents of the Association for Academic Surgery, several presidents of the ACS, as we've noted, and American Surgical Association, several department chairs, the incoming executive director of the ACS, the incoming president of the Brigham and Women's Hospital, the incoming CEO of UAB, University of Alabama, Birmingham, as well as a few deans of medical schools, to throw a few in there. SBAS has also been successful in nurturing women surgical leaders. Dr. Patricia Turner was our first woman president, soon to be the executive director of the ACS. Our immediate past president, Dr. Andrea Hayes, is the incoming chair of surgery at Howard University. And our current president is also another outstanding woman surgeon, Dr. Carla Pugh from Stanford. However, we still have real challenges to address. This article by Crown and colleagues was recently published in the Annals of Surgery. It is a survey from SBAS examining the role of race and gender in the career experiences of Black or African-American academic surgeons. It shows that Black women experience more gender bias, receive less effective mentorship, and are promoted less frequently than men. We have work to do. I leave you with this powerful example of what great role models and sponsors can do. This picture shows a recent graduating class from the Department of Surgery at the University of Miami. These residents matched with us between 2013 and 2015. Ladies and gentlemen, here is a new class of categorical interns at the University of Miami. It consists of 6 diverse women and 1 male. This transformation is the result of Dr. Omaida Velasquez becoming chair of the DeWitt Daughtry Family Department of Surgery at the University of Miami, the first and only Latino chair of surgery in the country. The rest is history. So never underestimate the power of great role models, the power of mentorship, and the power of sponsorship. I hope that I've been able to convince you that diversity matters, and I hope I've demonstrated to you why we need both ethnic and gender diversity, not only to ensure the vitality of our noble profession, but also to effectively address health disparities and promote health equity. I leave you with these practical approaches to address gender and racial or ethnic inequities in surgery. I submit to you that if academic health systems embrace and adopt these principles, like the University of Michigan and Massachusetts General Hospital have already done, I'm convinced that we will attract the brightest talent to the field of surgery, and I won't have to worry about who's going to be around when I need my life-saving surgery sometime in the future. It has been a distinct honor to deliver the Strauss lecture. And Dr. Wood, I thank you again for the honor of coming here. Well, not quite coming here, but of getting a chance to meet your amazing faculty. Thank you.
Well, Dr. Ford, what a tremendous and inspiring and troubling lecture. I think both. I think you have articulated what we know are issues and that are systemic disparities that are deeply embedded within our systems, and that departments of surgery are probably bastions of some of the most embedded historical and institutional disparities. Your last slide shows some bullet points of things to do, which anticipates what my first question was going to be, and I'll see if other questions come up from the audience. But I'm reflecting back to my meeting last night, where we had a virtual visit for fourth-year medical students interested in our residency programs. And it was a visit that we dedicated to our Diversity Council, our Women's Council, and our Wellness Committee. So that's what the three things that we focused on. And actually, I think covered many of the things that you talked about. But I guess I'm going to reach deep and say, I'm a white male chair of a department of surgery. What guidance do you have for me to help lead a department to grow in the ways that you've outlined? Now, beyond the bullet points that you have, there's a deep aspect of cultural aspects as well. So what can we do to be better at the University of Washington?
Well, you heard me say this morning, many of the people who are responsible, my mentors and sponsors, who are responsible for helping me become the person that I have become, they were not Black. They happened to be white males. The person who really helped, the person who drew me into surgery ultimately was Dick Wilson. Dr. Wilson at the Brigham. He was a person who told me that I could have a future in academic surgery. It was just a case of mentorship. And it was such an innocuous discussion in front of an elevator. But that little exchange was life-changing. So a word of encouragement from you to URM student and showing any kind of interest in that individual could be life-changing. It doesn't have to be something dramatic. This is the power of mentorship, and that's the power of sponsorship. And the sponsorship from Dick Wilson was, he decided, you need to go do a sub-by at Sloan Kettering and then meet Tom Shires. I was from New York, and so he mapped out all of those things. So those are that's the kind of advice that I would never have had, because as I mentioned this morning, I didn't fit the prototype of people going into surgery at Harvard back in 1983. And the same was true for Tom Shires. Okay, I mean, I thought I knew better. I wanted to go to the Rockefeller University, but he felt that I would do far better if I trained with a surgical immunologist who would be able to look at from. And I think, to me, that's what mentorship and sponsorship is all about. And to a large extent, this is the same thing that I've tried to emulate for everybody. It doesn't matter. I mean, it doesn't. Those principles apply for all students, for all learners. And so, to the extent that you are conscious of those things, Doug, and I know you are, then you've already leapfrog above most others. And then there are some other support systems that can be established to ensure that once you have young faculty, residents, and so forth in your department, they are nurtured, they are supported, they get access to the resources, and most importantly, they have a mentoring faculty that meets with them regularly, that's concerned, make sure that they feel that they are part of the family, and this way they'll be able to reach their full potential, because the only thing that would differentiate them is their work ethic, sweat equity, and overall performance. And that's leveling the playing field. And for what I know that's happening at in the Department of Surgery, it's been exemplary. And certainly I've been impressed from the time I visited the department back in 2009, and once you've taken over as its leader, these are very important topics, and you are emphasizing them. And so just keep doing what you're doing.
Well, thank you. I think this is always going to be a work in progress. I feel like we are making progress, but I think the more progress we make and the more I learn, the more I realize how far we have to go. I do have a question that's going to challenge you a little bit. So a question about normalizing parenting and family demands for all genders, rather than lengthening the tenure clock for women, as you promoted. The concern being that lengthening the tenure clock for one gender has the effect of normalizing gender disparities and behavioral expectations instead of changing those expectations. So how would you respond to that? I think that's an excellent question.
No, I love it. I mean, it's quite provocative, but I just want to focus on the facts. I don't want to confuse anybody with the facts. If you look at which gender, which group was affected by the global pandemic, it was women. It wasn't the males. Academic productivity, it tanked for women because they still had to worry. Our society is such that they have to not only worry about productivity on the professional side, but work-life conflict remains a real reality. And until we have a way of leveling that playing field such that it's an equal responsibility, it's an equally shared responsibility, then we have to be able to make exceptions. And maybe what needs to be done, if people are not ready to do it, to apply this rule across the board, is when someone makes that request, we honor it. And that's the way we have to, that's the only way to approach it so we can level that playing field. Yeah, because our society is such that most of the burden historically has fallen not on the males, but on the women. And that's what the data have shown. And to that extent that we're dealing with that fact, we need to make some adjustments. I don't think the cultural shift is going to happen overnight. That is for sure. So while we await for that time, we await that time when there'll be equal sharing of responsibilities. We need to make some adjustments because the danger for us, the danger here is that we are going to lose the most brilliant group of people because they're not going to, you saw the statistics, 40% are dropping out after 6 years. So who's going to take care of us? Where are the surgeons going to come from? And more women now are going to medical school, are going to be graduating from med school than men. So we have to adjust our approach. We cannot continue to do things the way we used to.
I have another question for you. A question of, can candidate slating, otherwise known as the Rooney Rule, work in medical schools where positions aren't filled until underrepresented minorities are included in the interview process?
So the answer is no, because again, we have to talk about excellence. We everything we do has to be really in excellence. If the overarching priority is to just put a Black or brown person in the class and that person is not academically prepared, then you're doing that person a disservice, because that individual may not be able to keep up with the pace at which the material is going to be presented. And even if you have adequate support to help them, they may get frustrated. And then after 2 years, they have to leave and they have a debt of $200,000 and nothing to show for it. I think that is a disservice if you do that. So I really believe that, and the approach that we've taken, whether when I was in Pittsburgh, when I was in LA, and now certainly at the University of Miami, you look at the historical performance, you look at who struggled and where, and just come up with some objective parameters to try to find some predictors of success or failure. And then you tailor your admissions criteria accordingly. Because if you know that somebody with a certain GPA or certain score from a certain background is not, he struggles or ends up failing or not making it through, not graduating, then there would have to be something really, really exceptionally unusual for you to want to admit yet another similar candidate. Because this is what Einstein said, right? That's the definition of insanity. So I am all about making sure we have the right support mechanisms to bring in a diverse student body, but it should be every decision that we make has to be rooted in academic excellence. We have to have some normative criteria that suggests that this individual with some support is going to be able to meet the exigencies of the curriculum at the University of Washington or University of Miami and will graduate. Because the worst thing we can possibly do is to bring in people who are not prepared and watch them get frustrated, lose confidence, and then walk out owing $200,000 with nothing to show for it.
We're going to finish with one last question, and this is from Dr. Elena Quiroga, who is the chair of our Diversity Council and one of our outstanding vascular surgeons. She asked a question about the variety of DEI committees and councils around the country. And how could we work amongst each other better? How could those groups communicate better, join efforts, share best practices and successes and tips to maybe leverage or be synergistic with each other beyond each individual institution?
I think that's a great question. And this is something that I am particularly passionate about. So there are a couple of approaches. We try to share our approach, I want to say best practice with other medical schools in the state of Florida. So we have a council of medical school deans for the state of Florida. And there, we had a task force on racial justice that came up with a number of recommendations to promote racial justice, the health equity. And we have shared those recommendations with the other schools. We've made presentations. So that's one of them. The other way that I have tried to get more input is through the AAMC. David Acosta, who is the Chief Diversity Officer, is tremendously experienced and he knows a whole lot about the topic, and he's in contact with just about all the medical schools. So this is one, I think the AAMC would be a great, clearinghouse for best practices and can possibly engage a number of other departments, other schools of medicine to share what is probably the practices that are most effective across the board. Because that's really part of what that office does, is to monitor what each medical school is doing across the country and to then disseminate this information. So that would be a great way to go.
Well, Dr. Ford, you've been so generous with your time and inspiring with your ideas. We knew this was going to be great. You did not disappoint. Thank you for challenging us and also giving us a path of things that we can be working on to try to improve diversity at UW and beyond UW in surgery. So thank you for being with us today for our Harkin Symposium, for your earlier lecture on your path into academic surgery, and for this very important 72nd annual Alfred A. Strauss visiting lecture. It's been exactly what we aspired to. It's why we wanted you to be with us. And I just want to thank again Dr. John Strauss and Mr. John Friedlander for their ongoing support for this and for the activities of the Department of Surgery. So I wish you well, Henri. I hope you can now go have some dinner and enjoy a good weekend. I wish we were going to have dinner together here in Seattle, but maybe soon we'll be able to be together. Thank you so much. And thank all of you for joining us for this year's meeting.
Thank you and good night.
Take care.